All right, so next couple conferences are going to be having to do with lung cancer and neoplasms. So starting with this case, what are the findings here that anybody wants to discuss? What do we have on this cat?
Speculated, right, very high.
Yeah, so we have this right hilar spiculated mass. What do you think that is? Could be what? Do you think it's lymphadenopathy? Do you think it's parenchymal, or do you think it's hilar lymphadenopathy? The fact that it's spiculated suggests that it's what? That it's parenchymal, right? So what do you think that is? Well, the topic of the talk is, all right, so we think that's a lung cancer, but are there other findings here that increase your suspicion that that's a lung cancer? Right, so there's a risk factor of emphysema, patient has emphysema. So whenever we see emphysema on a CT scan, we know that that's a risk factor for lung cancer, so that increases our index of suspicion. Is there anything else? Anybody see another risk factor for lung cancer in this patient?
Pleural calcification.
Yeah, they're pleural calcification, so what's the significance of that? Asbestos exposure, right. So these are asbestos-related pleural plaques, also increasing the risk factor for lung cancer, okay? So predisposing factors, smoking, asbestos, of course, any disease associated with significant parenchymal scarring can also increase the risk for lung cancer. So tuberculosis, asbestosis, idiopathic pulmonary fibrosis, scleroderma, just to name a few. But severe fibrosis in the lungs also increases the risk for lung cancer. In terms of the cell types, adenocarcinoma is the most common. What used to be called BAC is a well-differentiated adenocarcinoma. It's a subtype. Then we have squamous cell, small cell, and then large cell anaplastic, roughly the percentages of the types of cancers we tend to see in the United States. Now, if I tell you that this lesion here is a adenocarcinoma, on the other side, we have this smaller ground glass attenuation opacity. What could that be? Well, one concern is that it might be metastatic disease, right? So that's a consideration. What else? Second primary? Somebody mentioned it over here. Atypical adenomatous hyperplasia. What's the significance of that? So first of all, what are the radiologic findings associated with atypical adenomatous hyperplasia? Yes, pure ground glass, small lesion, usually less than 5 or 6 millimeters, okay? And do these transform into lung cancer? No, they don't. But they are found in patients with lung cancer, so it is a marker that the patient can be at increased risk for lung cancer. So what atypical adenomatous hyperplasia of the lung is that these areas of abnormal proliferation of cells, and it turns out that when we follow them long-term with CT, they don't seem to progress to cancer, but they are found as a marker in patients with lung cancer. Usually these are pure ground glass attenuation nodules. There may be more than one. They tend to remain stable on follow-up examinations, these small ground glass attenuation opacities. Of course, there are other things that could also be in a differential, like inflammatory lesions, etc. But if we're talking about we're talking about abnormal proliferation of cells, something that's pure ground glass and small, it tends to be atypical adenomatous hyperplasia. And it can be found in up to 10 to 23% of patients with lung cancer, and it can be multiple in these patients with lung cancer. Okay? So here we have a lesion with central calcification. Is this benign? Well, it's got spiculated borders, right? So then that does increase your suspicion. So we can't assume the lesion is benign even if it has central calcification. So what kind of malignancy might this be? What cell type? Adenocarcinoma, why? Well, any tumor can develop dystrophic calcification, okay? But the fact that it's somewhat peripheral and spiculated nodule, I mean, that kind of goes with adenocarcinoma. What are scar carcinomas? What cell type are scar carcinomas?
Scar.
Scar carcinomas tend to be adenocarcinomas. All right, so carcinomas that occur near granulomas or can actually engulf granulomas, those can be adenocarcinomas, so-called scar carcinomas. So in patients with scarring, tuberculosis, etc., adenocarcinoma tends to be the tumor. So these tend to be peripheral. It's the most common cell type in non-smokers. They grow slowly, metastasize early, and the most common cell type of scar carcinoma is adenocarcinoma. Okay, so what is the finding on this chest radiograph? Well, I wouldn't call that reticular opacities. What would you, I mean, reticular opacities are kind of linear.
I would call both reticular and airspace.
Yeah, so there's definitely some airspace disease here. So you're reading this chest radiograph. What are you going to say? You're going to say what? What are you going to call that? What? Is that what you're going to say? You're reading a chest X-ray from the ER and you see that, you're going to say get a CT?
Okay.
What are you going to say?
I always check epic, check the white counts, check the fever, pneumonia.
Well, what are you going to say about how are you going to describe, you said pneumonia, how are you going to describe the X-ray? You're going to say, what does it show?
Vascular airspace opacities.
So consolidation, right? So you have a consolidation there. It seems to be in the left lower lobe, okay? So your first thought, of course, if you're looking at a chest radiograph and there's a consolidation in the lung, your first thought is what? Pneumonia, of course. But I'm telling you that the X-ray is unchanged for 6 weeks. So what is a differential diagnosis for airspace disease that is unchanged over a long period of time like that? What could that be? Well, how do you fit that in with cancer? How could that be cancer? So mucinous producing tumor, like a well-differentiated adenocarcinoma, yes. Is there another way this could be cancer?
It's like obstructing.
All right, so post-obstructive, right. So post-obstructive pneumonia, that's why whenever we read a chest radiograph from the ER and we read it as pneumonia, we always include the line that says, hope you guys include that line that says, follow-up radiographs to resolution. Because if it doesn't get better, you may be dealing with a post-obstructive pneumonia, all right? So certainly, the neoplasms you might worry about are well-differentiated adenocarcinoma, like a mucin-producing tumor, like you said, that can present as airspace disease, post-obstructive pneumonia. What about non-neoplastic? What kind of pneumonias might give you chronic airspace disease? What? Yeah, organizing pneumonia, except this seems to be unilateral, right? Organizing pneumonia tends to be a bilateral process. Tuberculosis, yeah. So tuberculosis infection can give you chronic airspace disease. What other type of infection, pretty rare around here, but can also give you chronic airspace disease? So fungal infection. So fungal pneumonias can also give you chronic airspace disease. So those are certainly things to consider. If it's a bilateral process, then you might consider inflammatory disorders like organizing pneumonia. Okay? So the CT scan in this case just showed the nonspecific consolidation, and this indeed was bronchoalveolar carcinoma or well-differentiated adenocarcinoma. So if we're talking about neoplasms and airspace disease, so what neoplasms can present as airspace disease, the most common would be mucinous adenocarcinoma. What's another rare neoplasm that can also present as airspace disease? What? Lymphoma. Yeah. So lymphoma involving the lung, non-Hodgkin's lymphoma, if it's limited to the lung parenchyma, can also present as airspace disease, but that's a much rarer neoplasm, okay, than these bronchogenic tumors. So these used to be called bronchoalveolar carcinomas, subtype of adenocarcinoma, not associated with smoking. Repeated growth, meaning that they grow along the airway walls without destroying the lung architecture or distorting the lung architecture. And that's why we can have air bronchograms. It can also spread through the airways, so you can have multiple foci of tumors. And because it's mucin producing, can't present with bronchorrhea. In terms of the radiographic presentation, still solitary nodule is the most common, although it's notorious for presenting as consolidation. And if it spreads through the airways, can present as so-called acinar nodules. These are small, fluffy, 5 to 6 millimeter nodules. So solitary mass here, still the most common presentation of these tumors, but they can be multifocal. Notice that there's more than one foci of tumor here. And ground glass attenuation associated with lung cancer tends to indicate better differentiated portions of the tumor. So it's associated with a better prognosis, okay? So the ground glass tends to indicate well-differentiated portions of the tumor, and that's because of this lepidic growth. So the lepidic growth is when the tumor grows along the alveolar lining like that, and so you can get airspace disease, you can get ground glass opacity without it really distorting the lung architecture itself. Now, another feature that can be associated with these tumors is called pseudocavitation. Those are these bubbly lucencies. So these may represent dilated bronchioles, and this also is a result of lepidic growth without destruction of or distortion of the underlying lung architecture. So bubbly lucencies, pseudocavitation is another high-risk imaging finding if we happen to see that on a CT scan. And we talked about spread through the airway, so acinar nodules. So these kind of fluffy, small nodular opacities throughout the lung, this is a result of airway dissemination. Actually, your first thought if you see an X-ray like this is not going to be neoplasm. What's going to be your first thought? You see an X-ray like this, what's the first thing on your differential?
Miliary TB.
Not miliary TB. No, miliary presents as what? It's tiny nodules, right? These are too big, okay? So what would be your first thought? What? Well, pneumonitis is a very nondescript term there.
And not metastatic disease?
No.
Then
Bronchopneumonia, right? This represents airway dissemination of a process. So bronchopneumonia, especially from bronchogenic dissemination of in Newark, tuberculosis. Okay? So bronchogenic dissemination of tuberculosis can also look just like this. So if you think of bronchogenic dissemination when we see something like this, and you think of pneumonia. Okay? So the term BAC, which used to be used in the past for these well-differentiated adenocarcinomas, these tumors are now called adenocarcinoma in situ. These are when they're very small with lepidic growth, minimally invasive adenocarcinoma. So here there is some invasion, although it's a little bit. And at these very early stages, patients can have 100% survival if the tumor is resected. So we talked about this, ground glass attenuation nodule less than or equal to 5 millimeters. AAH stands for atypical adenomatous hyperplasia. Does this transform to malignancy? No. But if we had more ground glass opacity, if it's somewhat larger and it is a neoplasm, that could represent AIS, which stands for adenocarcinoma in situ. Right? So if there's a solid component associated with this, and we are thinking about cancer or neoplasm, then it could be minimally invasive adenocarcinoma. And then if we have a larger solid component with ground glass opacity, then we're talking about lepidic predominant adenocarcinoma, non-mucinous. But when you have consolidation, especially multifocal consolidation, airspace opacities, air bronchograms, then we're talking about invasive mucinous adenocarcinoma. Okay? These used to be called BAC in the past. This is the terminology now that is used by pathology. All right? Okay, this radiograph. What does anybody have to say about this? Well, can we have somebody besides Jose participate here? Yeah, so there's right upper lobe atelectasis. Yeah, so what's the S sign of Goldman?
You see like.
Well, what's the significance?
You see like a bulge of the horizontal,
Yeah, there's-
oblique fissure?
Yeah, there's a bulging here of the fissure, so the significance of that is what? Mass, central obstructing mass. So this is obstructive atelectasis then from a central obstructing tumor if we have the S sign or the reverse S sign of Golden. So we have right upper lobe collapse, but there's a bulging in the fissure. So usually that means that there's a central obstructing tumor, there's atelectasis, but this portion of the fissure is not able to collapse against the mediastinum because of the presence of the central tumor. So that is the S sign of Golden or reverse S sign of Golden, and it's associated with central obstructing tumor. The cell type of this tumor you might suspect is what? Squamous cell, yeah, there's obstruction of the right upper lobe bronchus, a large central tumor. This was squamous cell cancer, okay? What do we have to say about this radiograph? Don't criticize my film. All right, so why do you think there's right middle lobe atelectasis?
Can't see the right heart border.
Okay, so we can't see the right heart border, so we suspect some process involving the right middle lobe. Why do you say it's atelectasis?
There's a mediastinal shift to the same side to the right.
Okay, so it seems to be maybe a little bit of shift to the right side. What do you think of the position of the right hilum?
Maybe a little bit of inferior tract.
Right, so maybe it's slightly inferiorly displaced. You know, we don't have a very good interlobar pulmonary artery on this side, so maybe it seems to be pulled down a little bit. So does that suggest anything more? Well, do you see the right diaphragm? No. So when you lose the right heart border and you lose the right diaphragm, and there's volume loss, we suspect what? Yeah, obstruction of the bronchus intermedius with combined atelectasis of the right middle lobe and the right lower lobe from obstruction of the bronchus intermedius, okay? And here's the bronchus intermedius. There we have an obstruction there in the bronchus intermedius. Here's the collapsed right middle lobe. Here's the collapsed right lower lobe. Of course, these things are blood vessels. What are these darker things? What are these things? So those are airways that are filled with secretions because there's obstruction here, so the air can't get in it, so it fills with secretions. So instead of air bronchograms, you have secretions filling the bronchi, and that's what you're seeing here on the CT. So what is our differential diagnosis? Oh, by the way, what is this stuff? Yeah, those are tree and bud nodules, so it looks like a little bronchiolitis there. What's our differential for this? What could this be? So mucus, do you think that's mucus, yes or no? Yes or no? Do you think that's mucus? Well, first of all, given the topic of the talk, but why not, why, you look at this and you say, oh, I don't think that's mucus. Why? The density, what's the attenuation of mucus?
Lower.
Yeah, it should be fluid attenuation, right? So a big mucus plug should be fluid attenuation. That is soft tissue attenuation, okay? So we don't like mucus for that. So what's our differential? What kind of neoplasm? Somebody said?
Carcinoid.
Yeah, certainly carcinoid. What would be the most common neoplasm you would mention? What's the number one neoplasm? Not adenoma. Squamous cell cancer, right. So the most common neoplasm would be squamous cell cancer, but certainly whenever you have a central airway lesion like that, you do have to consider carcinoid also in the differential. And then there are other more unusual tumors that can arise within the airways. Neoplasms, what are they? What are those cell types? They arise from salivary glands, which is why it's the same cell type you would see in the salivary glands in the neck. What kind of tumors are those? Well, what are the tumors you see in the parotid?
In the parotid?
Yeah.
We have malignancies, adenosystic.
Yeah, so adenoid cystic cancer and mucoepidermoid tumor. So the differential for an endobronchial neoplasm, right? Squamous cell cancer, carcinoid, and then we have more unusual tumors that arise from salivary gland rest, like adenoid cystic carcinoma and mucoepidermoid tumors. Okay? So those are the primary lesions that can arise within the airway. That was a squamous cell cancer, by the way. What do we think of this case? Yeah, so we have this abnormal opacity here on the left side. So why are we suspecting left upper lobe collapse?
Because you can see like lucency at the top of the
So,
superior.
yeah, so there is lucency. Well, first of all, is there volume loss? You're saying collapse, is there volume loss? Yes or no?
Yes.
Well, which is it?
Yes.
How do you know?
It's the high level
Well, where's the right heart border?
it's shifted.
Yeah, of course, the right heart border is shifted to the left side. What about the trachea? Maybe a little bit of shift to the trachea, but the right heart border does seem to be shifted towards the left side, so there's volume loss there. Now, you suggested this lucency here, suggesting left upper lobe collapse, so what is the sign called? It's called the Leucical sign. So why do we get the Leucical sign with left upper lobe atelectasis? What gives you the Leucical sign when you have left upper lobe atelectasis?
You're seeing like superior.
Compensatory hyperinflation of what? What part of the lower lobe?
Superior.
The superior segment. So when we have left upper lobe atelectasis, you can get compensatory hyperinflation of the superior segment of the left lower lobe, which becomes border forming with the aortic knob, and that gives you this lucency here, which is the Leucical sign. The best radiographic view for demonstrating left upper lobe collapse is what? Lateral view. So notice on the frontal view, left upper lobe collapse is pretty sneaky. Right? It's not always easy to tell what's going on. But on the lateral view, what do we have here? What is that? Yeah, that's the major fissure that's displaced anteriorly, and then all the opacity anterior to that represents the collapsed left upper lobe. So the lateral view is the best radiographic view to actually demonstrate left upper lobe collapse. So here again, we have a central tumor, somewhat necrotic. This was also squamous cell cancer with left upper lobe atelectasis, and this is how we get the Leucical sign. That's compensatory hyperinflation of the superior segment of the left lower lobe, which becomes border forming with the aortic knob, giving you that lucency. Leucical is air sickle. Okay? And what about this case? So there's whiteout of the left lung. The two major causes of whiteout are large pleural effusion and complete atelectasis, which is this. Yeah, so this is complete atelectasis of the lung. The heart is completely shifted over to the left side. Okay, and it also looks like maybe there's some cutoff of the left bronchus here. Okay, so in this case, there's complete atelectasis of the lung, and you can see there is obstruction of the left main bronchus. And this is why I say whenever you're dealing with these abnormalities, it's best to do your CTs with contrast. Because with contrast, we can see differential enhancement of the lung parenchyma here. You see how the lung parenchyma enhances a little bit differently than the actual tumor. So the tumor here is exerting mass effect on the left pulmonary artery and also extending into the left main bronchus. You can see the distorted vasculature because of the neoplasm. So whenever you're dealing with these larger abnormalities, especially with atelectasis, it's very important to do your follow-up CT with contrast. And then there's also a very nice correlation with nuclear medicine. So you can see the extent of the tumor correlates nicely. Notice that tumor enhances a little bit differently than collapsed lung. You can see where the tumor is here on the PET scan correlating with that, and also here on the axial images where you have tumor and where you have collapsed lung. And here you can also see on the PET scan the tumor actually extending into the left main bronchus. Okay? Another example, this one is right upper lobe atelectasis, and then here we can see collapse, obstruction of the right upper lobe bronchus, and then just nondescript right upper lobe collapse on the CT. But it's when you give contrast that you can see the difference. So you see the difference here of the hilum, but also here of the lung parenchyma. Notice the collapsed lung is here. These are the vessels. Here is the mass. So the mass, the obstructing tumor, enhances differently than the collapsed lung. So CT with contrast is really helpful whenever you're evaluating cases of atelectasis. Okay. What's the abnormality on this chest radiograph?
It's like there's a left mid lung opacity.
Yeah, so we have this left mid-lung opacity. Here's a close-up. Anything else to say about that?
There's internal lucency.
Yeah, so the lucency could represent what? Cavitation, right. So if we see lucency within any kind of nodular opacity, we think cavitation. So what could this be? What's the differential diagnosis? So, presumably for neoplasm, squamous cell cancer is the most common neoplasm associated with cavitation. So what else is in your differential for a cavitary nodule? What? Infarct? Yeah, if you have a PE with an infarct, but more likely than that would be what? So TB, although this is one isolated lesion in the left mid-lung, but TB certainly is always in your differential for cavitary lesions. What else? So fungal pneumonias, any necrotizing pneumonia, and then, of course, around here, whenever we see peripheral cavitary lesion, we always bring up Newark. Peripheral cavitary lesion in Newark.
Sorry, what?
A peripheral cavitary lesion in Newark, we bring up septic emboli. Septic emboli, okay? Always have to think about that also, especially if it's peripheral cavitary. All right, so this has a rather thick wall, which the thicker the wall, that increases your suspicion of malignancy. This turned out to be squamous cell cancer. Also a little pleural tag here. You see that puckering of the pleura, which can also be an indication of neoplasm, although it's not a 100% rule that you're dealing with neoplasm. Another big cavitary lesion here. You can see a little bit of fluid within the mass. Here on the CT, this wall is really thick. So when you have thickened wall, look where the wall is thick. The thicker the wall, the higher your suspicion for neoplasm. This was another squamous cell cancer. Of course, this patient has risk factors. What's the risk factor here? Emphysema, right. Whenever you see that, your index of suspicion goes way up, and also there's lymphadenopathy here also. Okay, so that was squamous cell cancer. So these can be endobronchial, they can be peripheral. The peripheral ones are the ones more likely to cavitate. These grow rapidly, metastasize late, and hypercalcemia from ectopic parathormone production. That is also a paraneoplastic syndrome that can be associated with squamous cell cancer. Okay, so what's the finding on this chest radiograph? Do you think that's an airspace opacity, or do you think that's something worse?
No, it looks something like something
What would you call that? Yeah, so we have a right paratracheal mass, okay? So what could that right paratracheal mass be? Sure, certainly it could be lymphadenopathy, right? Might be a tumor up there in the right upper lobe itself, extending towards the mediastinum. Is there another finding on the chest radiograph? Where?
No, I don't know. Like in front of the scapula, maybe?
Yeah, no, like rib distribution.
Yeah, there's rib, this rib is missing,
Yeah, okay.
okay? So how do we put that together with this? Metastatic disease, right? So again, when we see something that might look like cancer, it's important to start going through your checklist of other things to look for: pleural effusions, other nodules, mediastinal nodes, bones. Look very carefully at the bones. So there's rib disruption here. So here we see our big central tumor, or lymphadenopathy. Here we see the mass with the rib destruction. What's our differential for this CAT scan? What could this be? Mesothelioma. Do you like this for mesothelioma? Why not mesothelioma? Why is that a bad choice? Well, first of all, mesothelioma is a tumor of the pleura, right? So just on the chest radiograph, you would expect to see some pretty extensive pleural thickening, which we don't have here. And almost all mesotheliomas are associated with pleural effusion. Okay? So, yeah, of course, they're my cases. So what else? What's in our differential? Squamous cell cancer. What is this guy? What is that guy? Yeah, well, the Asia's vein, what about it?
So small cell.
So, well, tell me about the Asia's vein first.
Dilated.
It's dilated, and what else? Why is it so bright?
Because there's a picture on that species.
But why is the Asia's vein so bright?
It's like reflex from that species.
Okay, so this is undiluted contrast that is going into the azygous vein from the contrast injection, because as you said, what's missing here? SVC. So this patient has SVC syndrome. So the azygous vein here is a collateral root. So whenever you see undiluted contrast within a dilated azygous vein or within other veins, chest wall, anywhere else, look carefully for central venous obstruction, because it's an indication that those vessels are acting as collateral vessels. The most common neoplasm associated with SVC syndrome is small cell cancer. This is a case of small cell lung cancer. All right. So by the way, so of course metastatic disease from any tumor can also be in your differential, but what else would be in your differential for, if this is lymphadenopathy, this looks like lymphadenopathy, what other tumor would be in your differential? Lymphoma, certainly lymphoma is also in your differential. Okay, this was small cell cancer. So, strongest associated with smoking, very aggressive tumor, most common tumor to cause SVC syndrome, paraneoplastic syndromes, Cushing's, SIADH, Eaton-Lambert, which is a myasthenia gravis-like syndrome associated with small cell. Usually presents as a central mass with extensive lymphadenopathy. So here's another case where we have right paratracheal lymphadenopathy. Where else is there lymphadenopathy? Right up here, left paratrachea, right? Look at the aortic knob. The aortic knob is here, and you have all of this density here. The trachea is even deviated toward the right. So you have extensive mediastinal lymphadenopathy, also pleural effusion. Okay? So extensive lymphadenopathy of the mediastinum, pleural effusion, this was small cell cancer. Another one with SVC syndrome. Notice undiluted contrast within the azygous vein, SVC obstructed. Notice collaterals in the chest wall. So when we see undiluted contrast within the veins on a CT, we want to look for central venous obstruction. Okay? Large cell anaplastic, this is another cell type of tumor, poorly differentiated, also associated with smoking, rapid metastases. These tend to be large lesions. Nothing specific really on imaging. Large neuroendocrine carcinoma is a subtype. That's a high-grade, poorly differentiated tumor. And so this is another cell type of tumor that you might run across. What's abnormal here? There's a normal chest x-ray. We're going to dictate, besides the fact that the lower portion is collimated off, as Jose is going to point out to us. But are we going to dictate this as a normal chest radiograph? Next case.
Thinking of the right lung.
All right, certainly. All right, so say this to yourself 3 times. The blackness of the lungs should go to the edge of the ribs. Okay, remember that rule. The blackness of the lungs should go to the edge of the ribs. When it doesn't, you have to figure out why. Here, the blackness of the lungs does not go to the edge of the ribs, all right? So there's an apical process, right? You have asymmetric apical pleural thickening. So in this lecture, you would be concerned about
Neoplasm.
what neoplasm? What do we call this? What do we call this? Pancoast tumor. This is Pancoast tumor, okay? So here you have an apical mass, and of course here you have rib destruction, which you couldn't see on the chest radiograph in this particular case. Apical mass with bone destruction, Pancoast tumor, okay? So superior sulcus, also called superior sulcus tumor, is a groove for the subclavian artery. Pain-coast syndrome, arm pain and tingling, and airline nerve distribution, Horner's, and it's due to apical tumor invading the brachial plexus and the sympathetic chain. These can be any cell type, most commonly adenocarcinoma. In Pancoast's original description, he describes superior sulcus tumor, pain in the arm, ipsilateral Horner's, destruction of bone, and atrophy of the hand muscles. Apical mass, asymmetric pleural thickening, especially if we have bone destruction. You might not always see bone destruction on the chest radiograph, so you still have to be concerned. So on CT, you would see the bone destruction, and of course with MR, we can look for extension towards the vertebral bodies and towards the spinal canal also. So here's a tumor in the apex, and remember the apex is the very top of the lung, so the apex is the tippy top of the lung. And you can see also there's extension into the vertebral body for this particular Pancoast tumor, okay? So the clinician comes to you and says, oh my goodness, there's all this asymmetric pleural thickening here. I have a patient with a Pancoast tumor. What are you going to say?
It could be, but it could also be scarring.
Well, you're going to have to do better than it could be. You're going to have to come up with one or the other, and which you're going to come up with.
I mean, there's volume loss because there's tracheal deviation, there's sort of like elevation of the.
So what do you think this is? I mean, is this Pancoast tumor or is this scarring?
I'd say more scarring.
Scarring from what?
Maybe radiation. Maybe resection. Then I don't know.
Well, anybody else have any thoughts? What do we think of the position of the right hilum? Elevated. Right. How do you find the position of the hilum? You find the interlobar artery, you follow it all the way back, you follow the trajectory of that vessel going back to the mediastinum, okay? So normally the left hilum is a little bit higher than the right. The right hilum should never be higher than the left, okay? So this hilum is elevated. Elevation of the hilum indicates what? Volume loss in the upper lobe. So there's volume loss here in the right upper lobe, okay? Is the left lung normal? Also, the trachea shifted over, which also tells you there's volume loss in the right upper lobe. Is the left lung normal? Well, are these opacities normal here in the left lung? No. Okay, so we have some abnormal opacities, and what part of the left lung is involved with these opacities? Left upper lobe, right? Especially towards the apex. You see these funny looking things over here, right? Yeah, so that's bronchiectasis. How do you put the picture together? TB. This is a patient with tuberculosis with scarring in the upper lobes, right? Look at the whole film and you find all of these and it goes together, right? So this is not a Pancoast tumor. This is a patient with tuberculosis who has extensive scarring, especially in the right upper lobe. Okay? Not a tumor. Okay? So this was all scarring in the right upper lobe, not tumor. Okay, big mass over here. Pulmonologist wants to do bronchoscopy, comes to you for your advice. Is this approachable by bronchoscopy? You will say,
Yes.
good. Where should I go? Is the next question.
To the right.
Yeah, it's good to go on the right side. That's a good start.
Right superior. Wait. No. Medial. No. Medial.
So where do we go?
Right medial. Locus.
Okay, so as we're coming down, so before you get the basal segmental bronchi, this bronchus has a name. What is that called? No, not the intermedius. The truncus basalis. I always forget that. Truncus basalis. After the superior segmental bronchus comes off to the lower lobe, you have the truncus basalis. which then divides into the basal segmental bronchi. And the order of that division is mouth, medial, anterior, lateral, posterior. So this one, you can see the obstruction here as we come down is in the medial. There's the anterior, lateral, posterior. So you would tell a bronchi, go to the medial basal segmental bronchus, and that's where you'll find the tumor. Right? That's where it is. Okay? So there it is there. There's an endobronchial component. Okay. Obviously, a right lower lobe mass. Are we done, or is there something else we need to mention?
It's going to the atrium, the left atrium.
So there is a filling defect here in the left atrium. So how does lung cancer get into the left atrium?
So the pulmonary veins.
Through the pulmonary veins, right. So lung cancer can grow through the pulmonary veins or can go around the pulmonary veins to get into the left atrium. On echocardiography, they would see the left atrial tumor. Of course, they're not going to see what's in the lung. So if a patient has an echo and they find a left atrial mass, right, realize that lung cancer invading the left atrium is actually more common than left atrial myxoma. Okay? So they're not going to see this, but they're not going to see this part. You will see this part, and you'll be able to say this is lung cancer that's invading into the left atrium. Okay? Here's tumor invading into the pulmonary artery, right? Here's lung cancer involving the pulmonary artery, complete collapse there of the left lung. Now, when you have advanced cancer, of course, you're going to talk about the tumor, the atelectasis, the lymphadenopathy, things you always want to think about. Look at the airways. So here you follow the airway down, you see that the bronchus intermedius is completely obstructed, and also some obstruction of other airways. So go through this checklist of things that you also can look at. Look at the pulmonary arteries, follow the pulmonary arteries. So in this case, you can follow the right pulmonary artery across here, and you can see that there is some encasement by tumor and some irregularity of the pulmonary artery branches. But don't forget to look at the pulmonary veins also. So here, when we look at the pulmonary veins, there's a nice left inferior pulmonary vein. You notice we don't have well-defined veins on the right side because there's involvement by the tumor. The tumor is causing obstruction there of the right inferior pulmonary vein and also some obstruction of the right superior pulmonary veins. Okay? So don't forget to look at the pulmonary veins also when you're dealing with cases of cancer. In the same patient, this patient has this interlobular septal thickening here in the right upper lobe. What do we attribute that to? What would you attribute that to?
Venous congestion.
So certainly when we see interlobular septal thickening in cases of neoplasm, one thing we always consider is what? Well, what do we call that? Yeah, lymphangitic carcinomatosis, right? So that's something we consider. But what goes against this being lymphangitic carcinomatosis? It's very smooth. So here you have smooth interlobular septal thickening, and then we mentioned, what did we say? Yeah, it's interstitial edema. Remember, this patient has obstruction of the right upper lobe pulmonary vein by the tumor. So localized areas of smooth interlobular septal thickening in patients with cancer are not always, certainly lymphangitic carcinomatosis is something to consider, but it's not always lymphangitic carcinomatosis. It can be interstitial edema from obstruction of the pulmonary vein, okay? What lobe is the tumor in? So, looks like it's in the lower lobe, okay? Now, if this patient is a surgical candidate, there's one other bit of information you need to tell the surgeon when you're looking at the CT scan about this case. It crosses the fissure, right. So this tumor is crossing the major fissure here, okay, going into part of the right upper lobe, it seems. So why is that important?
They just remove one lobe and won't take it.
Yeah, so the patient requires more than a lobectomy. So if the tumor is crossing the fissure, that's a very important finding that you have to mention when you're reading the CT scan. If I tell you this patient has lung cancer, what do we notice? Yeah, you have bilateral adrenal masses, so these are going to represent mets, right. Now, always important in your protocols when you're imaging for lung cancer to image all the way down to the adrenal glands, because the adrenal glands are a very common location of metastatic disease from lung cancer. Okay, so you have to include the adrenal glands in your chest protocols when you're imaging the patient for lung cancer. Now, I could have picked any case of adrenal mets, but I picked this particular one. Why?
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 Because it's involving veins.
Yeah, because you can see the tumor here actually going into the inferior vena cava from the adrenal gland, right? So tumors that invade the inferior vena cava, usually those are renal cell cancers, but adrenal tumors can also invade the inferior vena cava. Okay. So this patient comes in for a follow-up CT scan, is being treated for lung cancer, right? We're doing follow-up CT for lung cancer. So just a routine chest CT protocol for lung cancer on an outpatient. So in addition to describing the tumor and all the other stuff, the fusion and everything else, there is something else you should notice. What is that?
It's involving the right, like there's film defects in the right lower lobe part.
Yeah, there are pulmonary emboli here.
Yeah.
So this is not a PE scan, right? This is a routine CT chest protocol with contrast. There are clots. You can see filling defects there in the segmental pulmonary arteries. This is the most common scenario where you will see so-called asymptomatic pulmonary emboli in an outpatient. It's a patient with a history of cancer. So in all patients, they're hypercoagulable. In all patients with histories of cancer, when you're reading the CT scan of the chest, always have an index of suspicion for PE. Look very carefully at the vessels. They might be small like this. They could be relatively asymptomatic, although they will tend to treat the patient. The patient will get treated for the pulmonary emboli. So don't forget to look at the vessels very carefully, even though it is not a PE scan. You can still pick up these PEs on these outpatients. This patient was transferred to our hospital for a brain biopsy because they had this ring-enhancing lesion. They presented at an outside hospital, got worked up. They found this. They get a pre-op chest radiograph here right before they do the brain biopsy. What are we going to say? So what do we see? There's a left upper lobe mass. And so what's the point of this? The point of this is that lung cancer metastatic to the brain is much more common than primary neoplasms of the brain. Okay? So in these patients who have, whenever you get the history of a brain mass and they have a chest x-ray, have a high index of suspicion for lung cancer, because what happens is because of the patient's condition, you're not going to get a very good PA and lateral chest x-ray. You are going to get this kind of portable view that, as in this case, they may be using just as a preoperative chest radiograph. So you have to have a high index of suspicion to realize that, wow, there is a mass here. And so we're dealing with metastatic disease. We're not dealing with a primary brain neoplasm. That does change the management for the patient, right? So you're dealing with a tumor here. You're not dealing with brain neoplasm. Now, the only reason somebody might show you a bone scan in a lung cancer conference. Well, that doesn't help if it's an oral exam, does it?
Hypertrophic osteoarthritis.
Hypertrophic osteoarthropathy. So what's the finding of the bone scan?
Periarticular increase.
The cortices of the long bones. Right. So these patients can present with bone pain, and you have increased uptake in the cortices of the long bone. So this is hypertrophic osteoarthropathy, and this can be associated with lung cancer. Patients with lung cancer it's not metastatic disease. So this is a paraneoplastic syndrome associated with lung cancer. They develop bone pain, can have cortical thickening on radiographs, and can have abnormal uptake on a bone scan. Hypertrophic osteoarthropathy can be associated with lung cancer. Okay, so we'll stop there for today and we'll go on to